All right, I guess we'll get started now so that we can start the webinar. So, Bismillahir Rahmanir Rahim, wassalatu wassalamu ala Rasulil Kareem. So, welcome everybody to the last webinar for Ramadan, and thank you very much for joining us. So, we're very honored today to have Dr. Asim Shabbir with us. And Dr. Asim is a renowned surgeon in his field, mashallah. He is a senior consultant in bariatric surgery at the National University Hospital in Singapore. He is also an assistant professor there and the deputy head of the Department of Surgery at NUH. He has served as the past president of the Obesity Metabolic Surgery Society of Singapore, and is currently the General Secretary of the IFSO APC chapter, as well as the treasurer of the Asian Pacific Metabolic Surgery Society. He is also the Director Center for Obesity Management and Surgery, COMS, at NUH, and is also serving on the Singapore Task Force for the COVID-19 pandemic. Very well established in his field and a man of academic caliber. We really appreciate him for giving his time and joining us and presenting to us today the nutritional and metabolic complications following metabolic and bariatric surgery. So without any further delay, thank you very much, Dr. Asim, for accepting this invitation and joining us, and we welcome you to please present your talk.
Thank you, Tahir. I hope I'm clear.
Yes, we can hear you and we can see your slides.
Lovely. All right. Thank you very much. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for this great opportunity to be away and to be able to share whatever little knowledge I have with everybody here in the room. So basically, it is a subject which many people do not have interest in. We as surgeons forget that there is a life of the patient after surgery, and which is the most important part. So nutrition is something that we need to care for the patient. So what I will talk about today includes the macronutrient deficiencies, the micronutrient deficiencies. I will talk about certain people being vegetarian. I will talk about women in their childbearing age. I will deal with procedure-specific issues with nutrition. I will deal with renal stones, gallstones, and glycemia-related issues. So, of the macronutrient deficiencies, I chose protein deficiency because this is the most important deficiency that we see and the most important that needs to be addressed. And why is it so? Why does it happen? It happens because people are intolerant to proteins or dairy products. Some are lactose intolerant. They may be intolerant to proteins as well. We have pre-existing hypoalbuminemia, especially seen in patients with either nephrotic syndrome or those with diabetes where the kidneys are leaky. There's decreased intake of protein because of the inherent choice of food that some of these patients may have. And then for the first 6 months after, no matter what surgery we do, there would be a sharp decline in the number of calories they take. We would recommend that any patient who goes through bariatric surgery takes about 1 to 1.5 grams of protein per kg ideal body weight. So this is considering ideal body weight and not normal body weight. Then how do these patients with protein deficiency present? They may have hair loss, poor wound healing. The extreme kwashiorkor is very rare that we see. So this is a great study that looked at basically protein deficiency and it compared gastric bypass to sleeve gastrectomy patients. And as you can see, there are two parameters, the most sensitive of which you can measure is the pre-albumin and tells you the true state of protein deficiency compared to albumin, which is also measured in the study. The T's represent the timelines, the T3, T6, and T12. If you look at T12, just 12 months after gastric bypass, 38% of patients will have some degree of mild protein depletion, whereas 52% of sleeve gastrectomy patients would also have some degree of protein depletion. So most of us in the audience wouldn't have expected sleeve patients to be protein deficient. And here is a clear study that shows you that their concentrations of pre-albumin are lower. And similarly, in gastric bypass patients and sleeve patients, if you even look at their albumin, which is not a great marker, but if you look at albumin with a normal value gauged at 37 grams per liter, you would find that close to a quarter of the gastric bypass patients and about 16% of the sleeve patients do have such a degree of protein malnutrition. Generally, in bypass patients, if you're bypassing about 75 to 150 centimeters of bypass, protein deficiency, which is clinically manifestable, is rare. However, in other more malabsorptive procedures like the biliopancreatic diversion, it can be as much as 3 to 11%, or similarly true for long limb Roux-en-Y gastric bypasses. So that brings me to my next slide, which basically talks about whether limb length in bypass actually make a difference. This is a great study that was recently, I also shared on the group and was published in SWORD. The follow-up is only 1 year, so it's a short-term follow-up, but it gives you a great insight. Published from one of the great centers in Asia, from Taiwan, Professor Vijay Lee's center. And you can see here that if you look at protein deficiency, which is pre-op, only 0.5% cohort has a pre-op deficiency. But at 1 year pre-op, about 2% of patients would have protein deficiency. Now let's just look at the groups. You look at Roux-en-Y gastric bypass, 1.8%. One anastomosis gastric bypass, bearing in mind that Vijay Lee does about 200 centimeters bypass limb length. In one anastomosis gastric bypass, 2.8%. And even you can look at sleeve gastrectomy, not very far away from the Roux-en-Y bypass, standing at about 1.2% of patients would develop some degree of protein energy malnutrition. Now, if you look at this if you look at this column of protein deficiency here, you look at the total length of small bowel that they measured is about 6 meters here in the protein deficient group. The biliopancreatic limb length is about 220 centimeters here, whereas the elemental limb is about 251 centimeters here. But if you look at the common channel length, it is pretty short, which is 294. That is just about 300 centimeters in size in those patients who actually develop protein deficiency. So when the authors basically concluded that even in a gastric bypass, anything which is less than 400 centimeters of common limb, remembering that I think all of us do not measure total bowel length when we do either Roux-en-Y or one anastomosis gastric bypass. Anything less than 400 centimeters will basically increase the risk of developing protein deficiency in these patients, and you have to elongate. If they do go into severe protein deficiencies, you would have to elongate your common length to 400 centimeters. That may include shortening of the biliopancreatic limb or the Roux-en-Y limb, whichever you have to do to prevent related complications. Now we'll go on to the second issue, which is mineral and trace elements. So the picture here basically depicts the roles that they play, and I won't go into the details here, but why do these food nutrition or these micronutrient deficiencies occur? First of all, the intake of people who are obese is not very healthy, so the density of the healthy dense nutrition is less. Higher food, above 30% total kilocalorie, equates to a decreased vitamin A, C, and folate intake. When patient takes more sweetened beverages, they actually decrease their intake of calcium and vitamin D3. So these are some of the causes. And how does diet play a role? So if you were to get somebody iron and you want to increase his iron by oral intake, just by food, you got to limit the intake of zinc and calcium. You got to limit the intake of eggs, milk, tea, coca, coffee, walnut, and bran. Some of things which we in our daily life consume quite a fair bit. On the other hand, if you want to give somebody more calcium, calcium absorption is blocked by iron, by tea. Hopefully not many of us take red wine. On the other hand, if you look at vitamin D, statins block absorption of vitamin D. A very common drug used in a lot of obese patients. Similarly, E. A lot of, cardiac patients use this drug. So drugs play a definite role, and diet plays a definite role. And some of these things are what we want our patients to eat. Like you want your patient to eat eggs. You want your patient to drink milk. You don't want them to have coffee. You want them to have bran, but you're losing iron. So that's why supplementation becomes important. So patient factors, basically pre-existing deficiencies are common. After surgery, a whole load of factors that I've put here. One of the things that I find is, apart from adherence and the common factors that we hear about, is a lot of people are confused about using the commercially available products. Insufficient monitoring. Most of these patients would present either the most common presentation of nutritional deficiencies in the obese are normally anemia and neurological deficiencies or dysfunctions, as I would say. Now, why do they happen? If you look at, especially in gastric rule and gastric bypass, this figure basically tells you where most of the trace elements or their vitamins are absorbed. And you can see that in the first 30 centimeter or 1 feet of our small bowel, which is still jejunum at the moment, calcium, magnesium, iron, copper, thiamine, riboflavin, folate, A, D, E, and K have already been absorbed. And when you bypass, even the shortest bypass is 50 centimeters of biliopancreatic limb. It means we are depriving our patients of being the ability to absorb these vitamins by not getting food down the duodenum. And again, if you look here, in the second part or the first few centimeters of jejunum, the remaining vitamins to a greater extent are absorbed. Thus, the need for the later part where they can be absorbed for giving higher doses of vitamins. So now let's talk about specific diseases or processes that go on specific to deficiencies. So anemia. Anemia can result from the lack of iron, from B6 deficiency, B12 deficiency, folate, to the extent even copper, selenium, and zinc can result in anemia. And look at the global prevalence of anemia or anemia deficiency, and you can see Pakistan is in the moderate subclinical group where there is a lot of iron deficiency still present, second only to India. So deficiency is about 12 to 47% in the malabsorptive procedures. A good measure of deficiency of iron is serum transferrin. We must remember that in obese patients, the liver produces an acute phase protein called the hepcidin. And this hepcidin blocks the absorption of iron from the intestine. So by default, most patients who are obese would have certain degree of low iron levels. And what is iron needed for, apart from needing for synthesis of hemoglobin, oxygen, and electron transport chain, and even copper required for absorption of iron. And it is more so very difficult to treat in women of childbearing age. Most patients would present with fatigue, and hair loss is one of the common causes. So it needs post-bariatric supplementation because of the loss of the acid millennium, where ferrous is converted to ferric form of iron, which is absorbable here, Fe3 to Fe2. Vitamin C can be given to enhance its absorption in selective candidates. Avoid giving iron together with calcium, otherwise they will block the absorption of each other and it will go to a waste. Compliance issues we have. In my practice, when I used to practice this some time back, I would always try and supplement them with oral. even pre-operatively and consequently post-operatively. But what I found is that women in childbearing age, young men, generally at about 6 to 9 months will become deficient despite my best efforts. Some of them would not be able to absorb the iron that I give them, although they would be compliant, and they would have issues like constipation, and some would just not absorb it. So what I have now started doing is all my patients, when they come in for their bariatric surgeries, before they go home, I have a test done and I would give them intravenous iron. I use Pharinject, which is about 1,000 international units. I give them, and it is suffice for a year, so I can be in peace for a year. They can continue to take their Sangobiones thereafter. Zinc is the next thing that I wanted to talk about. In hyperinsulinemia, and this are especially our normal obese patients, because there is insulin resistance in our patients, and even the diabetics, the early diabetics, zinc is excreted in the urine, and a lot of people would develop hair loss, poor wound healing, and even change in taste. So I've not seen a study that has linked to the change in taste post bariatric surgery to a loss in zinc, but we know, and from my own study, I know that there are about 50% of patients who would develop taste change to a certain degree. Whether this is due to zinc deficiency or not, it is hard to establish. I have personally not looked at it because it's an expensive test to do and to study. So 1 milligram of copper for each 8 to 5 milligrams of zinc. So zinc and copper need to be given into tandem because zinc results in sequestration of copper in the gut enterocytes. Now, if you talk about vitamins, there is a whole list of water-soluble and lipid-soluble vitamins. A, D, E, and K are fat-soluble, whereas the B series are generally, and the C are water-soluble. So biomarkers are labeled here. You can have an access to this presentation whenever you wish, and you can study them. And the presentations in brief are here. The ones I would like to talk about, number one, is vitamin D. Why is it deficient? Is it really sequestered in fat? If it is sequestered in fat, then when patients lose weight, they should release the vitamin D and their functions should come to normal, but that's not the case. Now we have this myth about sunlight exposure. So if you look at this sunlight exposure, I think some point in discuss it. Especially in our part of the world where people are rightly dark toned, the melanocytes do not tend to be very easy and helpful in helping with that conversion. Secondly, we do not drink fortified milk. The deficiency in calcium results in dysfunction of innate immunity, increased cardiovascular and autoimmune diseases, and many other regulatory mechanisms. So if we talk about having soaking sunlight and developing vitamin D, then the exposure of the arms and legs has to be from anywhere between 5 to 30 minutes, between 10 a.m. to 3 p.m., 2 times a week. How many of us who are morbidly obese are out there at that time for that amount of time in a consecutive period with both arms and legs exposed? Very few of us. Over-the-counter vitamin D2 is available, which is 70% less efficient than vitamin D3. So cholecalciferol, ergocalciferol, the vitamin D that comes in multivitamins is actually vitamin D2 mostly, and is not so effective. When there is inadequate vitamin D, you can generally prescribe about 800 to 1,000 international units of vitamin D3. The recommendation is generally anywhere between 3,000 to 4,000. I had been using ergocalciferol, which is vitamin D2, 50,000 units every week. However, it did not give me a great outcome. So I switched to cholecalciferol, which is vitamin D3, 25,000 international units. And if I replace this with a standard dose of vitamin D3 daily, I would, within 3 to 6 months, achieve normal vitamin D levels. Calcium. The bone mineral densities in morbidly obese patient is higher, given that the load that the bones need to take is more. Calcium requires an acid medium, and more transporters are in the duodenum for its absorption. So when you bypass the duodenum and when there is no more acid left in that pouch, absorption of calcium becomes a problem. If you have to replace your patient's calcium, then it is better absorbed in calcium citrate than calcium one is calcium aspartate and the other one's another profession, I forgot, carbonate, sorry. So calcium citrate is better. How do you monitor vitamin D and calcium? I monitor them using parathyroid hormone. If the levels start going up, I know the patient is not being compliant, either vitamin D or calcium intake is suffering. We should not overdo calcium intake as well, because in these patients, they are prone to develop calcium plaques in the vessels, and it will increase the risk of hypertension, stroke, acute myocardial infarction in the long future. So we have to be cautious in giving it. The next vitamin we'd like to talk about is vitamin B12. Here is how complex the absorption of vitamin B12 is. Suffice to say that the stomach produces an intrinsic factor which binds to B12, and then only it is absorbed in the terminal ileum. In patients who undergo gastric bypasses where there is no exposure and that bonding would had to happen within the stomach does not occur, vitamin B12 deficiency is common. I must say that in whatever little years of practice I've ever had, I've not seen a lot of vitamin B12 deficiency in Asians. I've had those 5 or 10 patients in a series of 1,000 or odd patients, but not really as much as it's reported in literature. So you see this this series published in SWORD, which said that the overall prevalence is about 18%, which in Asians luckily is not. This paper in gastrointestinal surgery, about 1/3 of the patients being vitamin D, B12 deficient after bypass. With supplement, it is reduced to 4%. And generally, about 500 micrograms per day is suffice. If for some reason they are non-compliant, they would need basically intramuscular dosing of vitamin B12. I think there's nasal spray as well that you can give these guys. Before I go there, I have seen a patient with vitamin B12 deficiency, a post-bypass patient of mine, come in with paralysis of the lower limb, and after replacement, it took her a good 3 months for the foot drops to recover. Vitamin B1 deficiency, reported a lot in English literature, but I haven't seen one in my Asian practice thus far. Maybe the alcohol intake is not that much in our part of the world, so we don't see it that much. B1 is largely absorbed in jejunum. It is important for the Krebs cycle. Severe deficiency results in beriberi, Wernicke's, and capillopathy. And if there is post-operative vomiting, this is where I would warn you, if your patients have it, do make sure. Some patients come with gastric, with anastomotic or anastomotic stenosis, or those coming post-leave leak where they've been vomiting. Do give them a supplemental dose. It does not harm the patient. You treat with IV supplements to improve outcome and delay. I think dose is 100 milligrams intravenous for 1 week, followed by 10 milligrams oral daily for 3 months is how you replace this. In my institution, we normally go through a pre-operative checklist. I do iron studies. I have a whole iron panel that I do. I do B12, folate, vitamin D. A and E are optional because they are expensive. Where do I do A and E? I do it when in women who are conceiving or have conceived, to make sure that the fetal development is normal. More extensive evaluation for those undergoing malabsorptive procedures like biliopancreatic diversion may be recommended, but not for routine. On the right hand on the screen, these are the 2016 ASMBS guidelines post-Roux-en-Y replacement, and you can see the dosing that they have recommended there. What I do is they have multivitamins. They take 2 tablets of multivitamins. which in those days was Centrum. When I used to give them this, they would take about 45 to 60 milligrams of iron, folic acid, and copper in those levels. Calcium citrate would be additional, so would be vitamin D and B12 written in the doses that you can see there. So we are giving vitamin D in about 3,000 units. What I have done over the time is I've worked with the farmer here. We've come out with a tablet. My patients take 4 tablets a day, and they have complete. So 2 tablets have calcium with the minerals and multivitamins, and 2 tablets have iron with the minerals and the vitamins. And they take 2 tablets morning, 2 tablets evening, and it is suffice to cover their needs, even if they go through Roux-en-Y gastric bypass. After a year of sleeve gastrectomy, I would reduce it to 2 tablets in total, whereas for bypass, I continue at 4 tablets. Now, let's go on to something which is a lot spoken about, vegetarian and then nutritional deficiencies. When I prepared this talk, I was surprised to see, I thought the vegetarians are the guys who only eat vegetables, but that's not true. There are vegetarians who are lacto-ovo-vegetarians. They consume dairy products like eggs. There are the pesco-vegetarians who can eat fish and seafood, and there are the vegans who would avoid any animal products. And it is important to know, because it influences practice. A cohort of our patients that we may even have in Pakistan, especially in the Sindh province, may be purely vegetarians. So in an Asian cohort, vegetarian dietary patterns were associated with higher incidence of morbid obesity, culminating in bariatric surgery. And why was this so? Because discouraged refined and processed food consumption and promote healthy vegetarian choices. So we found that they were eating more processed foods in this one. And so vegetarian does not necessarily mean that they're eating healthily. They eat a lot of ghee and stuff like that. And then a lot of carbohydrates, which make them put on a lot of weight. Now, if we do one anastomosis gastric bypass in vegetarians, and this talk I gave at the Asian Society meeting, where there were a lot of Indian surgeons who have a lot of vegetarian patients. Bypassing anything more than 200 centimeters of jejunum is not recommended because it results in hypoalbuminemia. Even the best vegetarian diets cannot keep up with albumin. Incidence of hypoalbuminemia in patients with one anastomosis or mini gastric bypass in vegetarians was 13%, which is quite a lot. So this is vegetarian bariatric surgery and omnivore like us. And you can see that basically at start, they are not any different from each other. i.e., if you look at their healthy, if they are supplementing themselves, there are no differences in their outcome in this study. However, the recommended daily intake of protein in bariatric surgery, even in vegetarians, is about 60 to 120. The protein consumed should be of higher biological value. And egg proteins, and you can see what converts to how much of protein. An egg, a medium-sized egg, has only 7 grams of protein. And if you see, I think the highest value is raw and mixed nuts. There are about 8 grams of protein in this. Ricotta cheese, milk is also there, only 5 about. So a glass, half cup of milk is about 4 grams of protein. Why is protein important? Protein is important in post-bariatric surgery because it gives rise to satiety. All right? And it also helps in thermogenesis. So equivalence to equivalence, 1 gram of fat is equal to 9 kilocalories. 1 gram of protein is equal to 4 kilocalories. Yeah? So you can see the difference. And thermogenic effect of protein is much more as compared to fat and carbohydrates. Another thing to remember is that a diet deficient in animal fat is deficient in omega-3 fatty acids, so we need to supplement them even in vegetarian population. Let's talk about pregnancy. Pregnancy, anemia is the most prevalent problem. High risk of protein and calorie nutrition deficiencies is seen in pregnancy. Most guidelines would recommend delaying pregnancy for a year till when weight has stabilized, or preferably by 2 years when the body has compensated a bit, to achieve best perinatal outcomes for mother and baby. There is no level 1 evidence to this, but I would say that if somebody is doing weight loss for a cause, to improve health, then they should let the weight loss happen, as pregnancy will result in weight regain. Having said that, I have published a series of my own patients who get pregnant much earlier than a year. If you manage the nutritional outcomes well, they do not have any perinatal complications. What is interesting is the study, which basically looked at 77 women who did not become pregnant, and about 39 who were in their 3rd trimesters. And they look at pregnancy after Roux-en-Y gastric bypass aggravates vitamin A deficiency and increases the percentage of night blind cases. So that's why I measure vitamin A in my ladies who get pregnant here, and can contribute to pregnancy and neonatal complications even as far off as 1 post-surgical year. So when I tell them, if you accidentally get pregnant, then please come and tell me at the earliest. If you're planning it, then let me know earlier so I can make sure you're optimized before you go on and get pregnant. So night blindness is common. Now, let's talk about some derangement. We will talk about hyperoxaluria and nephrolithasis. So renal stones have been reported often in patients who undergo Roux-en-Y gastric bypass. The dietary oxalate gets into the lumen, it's increased permeability, it gets absorbed, goes through the liver, and then excreted back into the urine, and then precipitates renal stones. Stone formation after bariatric surgery, higher incidence in obese patients, those going through surgery, 11 versus 4%. So relative risk for standard bypass is 2.15, but increases to 4.15 for more malabsorptive procedures like one anastomosis bypass, biliopancreatic diversion. So how do you prevent it? Basically by making sure your patients are well hydrated, they keep hydrated, they take diet which is low in oxalate, low in sodium, low in animal protein, and low in fat, and you largely use calcium citrate instead of oxalate, which basically helps in clearing of the oxalate from urine. Now, let's look at something which is called procedure-based. I used to argue that sleeve is basically a great procedure. It does not give you nutritional deficiency, so it takes me off the hook in having, and I am worried of following up my patients because they can do well. But this was an eye-opener study, and this is just about a year after sleeve gastrectomy. You can see that our patients are anemic, and a lot of them still are vitamin D deficient. And a lot of them are iron deficient, not only pre-operatively, but they continue to remain so post-operatively as well. So as I said, not only are the macronutrient deficient in sleeve patients, but also micronutrient deficiencies are prevalent. Here is long-term bypass data. I think I've shown this at PSMBS as well. And you can see that at 2 years, anemia being the most common deficiency, with iron and vitamin D topping the list. Okay. In my practice here, I find that iron and vitamin D are the 2 most difficult deficiencies that I find in treating over the long term and keeping people away from it as well. This is one anastomosis gastric bypass, and you can see The blue bars basically represent a limb length of 150 centimeters, the red ones 180, and the gray bars of one anastomosis bypass here represent limb length above 250. And clearly evident that this is basically the more length you bypass, the more deficiencies you get. The deficiencies are no doubt the same. So if you want to keep yourself at an optimal place where you get good weight loss and where you probably prevent excess amount of deficiencies, then a limb length between 150 and 180 seems to be a reasonable choice. This is produced by Professor Vijay Lee, I think. Yes, Vijay Lee himself, 15 years experience of OAGB. He is probably the guru of one anastomosis bypass in Asia. He's compared his Roux-en-Y gastric bypasses to his single anastomosis bypasses. And you can see that malnutrition in the RYGB happens in about 0.7% of patients. Anemia 0.6, whereas on the single anastomosis bypass, 2.5% of his patients would suffer malnutrition, anemia being about 1.4%. There, in comparison. Gallstones. So there's always been this weight loss surgery really result in patients actually having gallstones. We basically published some time ago, one of our countrymates, Yasser, actually published the paper for me. He looked at our patients a year out after bypass. There were 87 patients who started off with no gallstones, and out of them, 63 remained without gallstones. But a large number of proportion of patients actually developed new gallstones. And you can see that out of those 24 who developed gallstones, only one remained asymptomatic. Sorry, only one became symptomatic. But that, having said that, this is just 1 year follow-up. Beyond this, they may still become more symptomatic, but you can see that a good number, even I would say as many as 1/3 are actually becoming new gallstone carriers. A lot of people like to push the frontier and give ursodeoxycholic acid. A lot of patients dislike it for the side effects they have. This is a randomized trial that basically looked at 1 year evaluation of those patients who underwent the utility of ursodeoxycholic acid versus the control. They were analyzed, 2 patients with gallstones at 1 year, 3 patients with gallstone, 20 without, and 11 without gallstone. The outcome was that there is no difference in the short term of giving the oxycholic acid to reduce gallstone formation. If you want to reduce it, you probably have to give it for a longer period of time. Most people who do give it for 3 to 6 months, but probably they need to give it until the time that the weight is stabilized. But as I said, the biggest bugbear is compliance, and patients do not comply to it. Another nutritional issue related is dumping syndrome, which is early and late. The late one is largely hyperglycemic and insulinic response, whereas the early is rapid emptying. Just a brief account of it, patients need to take smaller meals with less refined carbohydrates, more complex carbohydrate, no eating and drinking at the same time. Start the meal with a protein. In refractory cases, octreotide and even revisional surgery needs to be considered. Postoperative hypoglycemia, which is termed to be as beta cell islet hypertrophy. People still argue whether this is really something which that can happen. There is a basic science paper that I've read which supports the theory, and it supports the fact that the beta cells are basically, they may not be replenished, but the stress that they go through, once it's over, they can rejuvenate themselves. So what do? You basically put them on a low carbohydrate diet, you put them on Archibos, and if it doesn't work, you may have to go back and reverse the surgery or even do something like a pancreatectomy. Now, we talked about protein deficiency and its consequences. One of the dire consequences of protein deficiency is loss of muscle mass. This is a paper that I published with my colleagues here, and you can see that after Roux-en-Y gastric bypass and sleeve gastrectomy, there's significant muscle mass loss up to about 24 months. When you lose muscle mass, especially in diabetic patients, what you lose is a big sink for glucose, i.e., the muscle can utilize glucose without the need for having insulin. So when you lose that sink, which is about 20% of muscle mass loss over 2 years period of time, your ability to handle glucose becomes poorer. So what we need to do is to learn our way in how to get our patients to exercise and preserve this body muscle mass so as they can basically dispose their glucose, especially the diabetics, in a better way. We live in the 21st century where we can use technology, and I love this paper which basically talked about how dietitians can use smart technology and guide their patients, follow up their patients, allow two-way conversations, and I would encourage practices to develop this communication and these kind of platforms where they can communicate instead, because most patients firstly do not like to see the dietitians. They say, oh, they will say the same thing. But if they're offside, they probably give them more insight into what they're doing. Useful tips for patients is basically correct deficiencies pre-operatively where possible, balance meals after their procedures, mix of proteins, veggies on your plates, vary meals, but try and make a large portion of your meals with proteins. If patients have a habit of snacking, then they should use proteins to snack and then see the dietitians regularly and comply to their things. Basically, the data I wanted to show you from InUEdge also shows the same thing, that most patients are actually deficient in vitamin D and in iron deficiency. Well, I think that was my last slide. Thank you very much.